Okay, so we're going to start out. This is just a basic oxygenation cheat sheet. I'm going to go over the main points of the entire chapter. Okay, try not to look at it as much as you can just because I don't want you to read to me.
Okay.
I want you to actually use your brain and think about it. Okay. All right. There's a couple things that I did not cover. So I added those to the sheet. And then this is just like overall view of the entire like oxygen, respiratory, oxygenation, everything on one page. So if there's anything for you to know, this would be the main stuff. Okay. All right, so we're going to start out with age-related differences of the anatomy, why we treat like little kids different than we do obviously older adults, okay? So in infants, their airways are small, and when they get sick, they wheeze, right? Because their airways are already this big, so you get a little bit of inflammation and they're going to wheeze. Okay. What's this noise called up here? Like if you heard like a kid choking and they make that noise, right? That how would you document that? Starts with an S. Ends with a triter. Strider. Good. So it's going to be Strider. That's a good start. Ma'am, do you need some coffee? Okay. All right. So Strider is the inflammatory noise we hear up here. Kids do that a lot because their airways are already small. We see that in choking and croup and things like that. And remember, their respiratory rate is way higher, right? So they're like 40 to 60 is about normal for them. If they're consistently over 60 and they're chilling, they're not crying, they're just laying there, then that's a red flag for us because that's pretty fast and they're not angry. Yeah. Now, if they're pissed, of course, the respiratory rate's probably going to be 70, and we would expect that. Or if they're hungry or panting or, but if they're just laying and chilling in the crib and they've got a respiratory rate of 70, then that's a concern. Their heart rate is also higher. It's 120 to 160, right? And they're at risk of aspiration because they haven't quite figured out the suck swallow yet, right? Yes, you have to wait for them to have certain foods, but if their respiratory rate in an infant that's under 12 months goes over 60, we have to put them in PO because at that rate, they're breathing 1 per second, right? Yeah. Now, if you put a boob or a bottle in their mouth, they're going to aspirate on it. They're going to, that means to bring fluid into the airways, and that's a really bad thing. All right. And kids get a lot of respiratory infections because they're in school, right? And they don't wash their hands and they're kind of dirty. So they get a lot of respiratory infections. This is when we see asthma emerge. This is when we see otitis media, which is ear infections. Okay. And we can see ear infections in infants too. In older adults, their alveoli is not as elastic. What is the alveoli? It's the sacs in the lungs. Okay. And what's their job? What's the job of the alveoli? Yeah, good. So it's gas exchange, right? So it's going to exchange the water wheel, right? The oxygen and the CO2. And their alveoli is not as elastic, which means it can't take in as much oxygen. It can't squeeze out as much CO2. Okay. They have decreased diaphragm movement. What is the diaphragm? So what does it do? It's a muscle of breathing. It's the muscle of breathing. Okay. And their diaphragm doesn't move as well. So then that means their lungs aren't going to move as well. They have decreased inspiration and expiration because their lungs aren't as elastic either. So they may take shorter, smaller breaths and they don't breathe out as much, which means they don't get in enough oxygen. They can't get out enough CO2. Beautiful. All right. You need to know meds that cause respiratory depression, okay? Because if you're giving those meds, you need to be very cautious with like your COPD, your asthma patients, because if it's causing respiratory depression and they already have a lung issue, we need to be really careful. Yeah. Doesn't mean you can't give those. It's just when you give them, you need to be like, are you sure you want to do this, right? Because if a patient has, let's say, COPD and their respiratory is already very depressed, right? Mm-hmm. And then you give them opioids, you may go in there and their respiratory rate is like 8. That's bad. That's bad. Okay. So opioids do that. Benzodiazepines, those end in PAM or LAM, and those are for anxiety. So like midazolam or lorazepam. Okay. So anti-anxiety meds, because in anxiety, your brain is like this and the med is meant to calm, but it shuts down kind of everything. Yeah. So that means it's going to decrease your respiratory rate and how much you breathe in. Anti-epileptics, those are seizure meds. Again, seizures are rapid electricity in the brain, and you give anti-seizure meds and it shuts down all your systems. Okay. And then there's a drug called dextromethorphan. You'll see it as like Robitussin DM. If you see DM, that's dextromethorphan. It is a cough suppressant. I'll tell you a giant red flag in nursing school. We never give cough suppressants. Okay. Because if you are suppressing the cough, what are you doing to the mucus? Yeah, you're pushing it down. And so when that mucus just sits in the lungs, it's going to get infected. So if you take a cough suppressant, chances are all you're doing is suppressing the cough. That mucus sits in the lungs and they're going to get a pneumonia. Okay. So there are very few times in all of nursing school you will ever pick a cough suppressant. I will always tell you what those are, but across the board, it's a no-no. Okay. All right. Normal breath sounds. They love to ask about this. It's also a health assessment question. They are called vesicular, the low pitch soft, and those are heard in all like your peripheral lung fields when you listen to the outsides, right?
Yeah.
And then bronchovesicular, whereas your bronchi, it's central. So you're gonna hear bronchovesicular. It's medium pitch, it's blowing, and it's heard over here and right here. Okay, so you've got bronchovesicular and then you've got vesicular. Okay. All right. What are some things that we can do as the nurse to improve respiratory function? So let's say all they give you is you have a respiratory patient. What are some things you can do to help them out? Yeah. What's the first thing you're always going to pick with a respiratory patient? If they say, what would you do first? They come in with acute respiratory distress. Positioning. In nursing school, you will always pick to sit them upright. And this is across the board for every module. Okay. If they give you a position and it's a correct position, then positioning will always be first because it doesn't matter what you do for this patient. If they're laying down, they're not going to be able to breathe. You could put on oxygen. You could do all kinds of things for them, but they're laying down and they can't breathe. Respiratory patients cannot breathe laying down and they have to be sitting upright. Okay. So anytime in nursing school, they say you have this in this patient, what's the first thing you're going to do? If the positioning is correct, you're going to pick the position. Okay. Yes, exercising is helpful just because if your lungs are moving and opening, you can kind of expel some of the junk, right? Always tell them don't smoke. Okay. For all of our respiratory patients, they need 2 to 3 liters of fluid. Okay. Why would I need so much fluid for a respiratory patient? Mm-hmm. Yeah, the mucus will thin. Okay. And the thinner the mucus is, the easier it is to cough up. Mm-hmm. There's no specific respiratory diet, but a healthy diet and something that's easy to chew. Because if you're having respiratory distress, you'll be able to eat a steak. No, they want something super easy to chew, which is usually something carby, right? Like pancakes or something like that. Something that's easy to chew. Decrease your chemical exposure, and that includes things like secondhand smoke or in your occupation. Like if you, I don't know, if you work at a dry cleaners, I probably would not. Okay.
Yeah.
And I like how it says avoid pollutants, but unfortunately, like even Houston, it's considered a polluted environment, right? So our air quality is not so good. This is a big one. The flu and pneumococcal vaccines. You will pick that as an anticipatory guidance for everybody. Okay. Especially our respiratory patients, asthma, COPD, all of those things, because the flu can cause a terrible pneumonia. And pneumococcal is the bacteria that causes most pneumonias in very little babies and very older adults. Okay. So you've heard of the pneumonia vaccine. That's what this is. It's a pneumococcal vaccine. It protects you against a bacteria that can cause pneumonia. Okay. Use a cool mist humidifier. Okay. And that's to keep all their airways moist. Okay. And a BMI of less than 25 because obesity obviously contributes to respiratory effort because you have more fat and things like that that are constricting you. Okay. All right. Next, we're going to talk about the diagnostic test I would do for a respiratory patient. So I would do a CBC. And why would I be doing that?
Temperature, but there's an air.
What is in a CBC? That's okay. So get out a Post-it and you have a homework. On the YouTube channel, there is a video called Decoding Lab Values CBC. Decoding lab values. It will tell you what's in a CBC, how to interpret it, because you're going to be dealing with CBCs all through nursing school. So the basics of it includes your white blood cell count, your hemoglobin and hematocrit, which tells us your white blood cells, and then your platelets. Okay, those are the big ones. There's a lot of other stuff in it, but those are the big ones. In this case, we would do a CBC on a respiratory patient to make sure they didn't have a secondary infection like a pneumonia or something like that. If they did, their white blood cell count would be high. Okay. Huh? The white blood cell count. That's right. White blood cell count. ABGs. What are ABGs?
Anyway.
What?
No.
Oh. It does. Where do we draw them from? It's blood. So ABGs is arterial blood gas. We draw it from an artery. Okay. So no, it's an arterial line because an IV is venous, intravenous, right? An art line is arterial. And we need arterial blood gases. So we're looking in the arteries because your veins aren't going to have very much oxygen, right? Because it's deoxygenated blood. So I need to look at my arteries and see how much oxygen's in there. Okay. So in ABGs, that includes your pH, CO2, PaO2, and your HCO3. Okay. And I think, wasn't there a video on that?
Yeah.
Okay. So you need to know ABGs and you need to know how to interpret them. That's definitely testable. Okay. All right. Next is a sputum culture. All right. So it's kind of misleading that it's called a sputum culture because it sounds like spit to me. I don't know if it's like that to you, but you want junk from the lungs.
Okay.
So when you're doing a sputum culture, you do it first thing in the morning. You have the patient sit upright with their legs hanging off the side of the bed. You have them rinse out their mouth because I don't want food in the sputum culture, right? What I'm trying to get is mucus from the lungs to see what's inside the lungs. Okay. And so after you rinse out their mouth, then you're going to give them a sterile cup and you're going to have them take like several deep breaths to try to initiate a cough reflex. And then they're going to, and then whatever comes up, that's what they're putting into the cup. I do not want spit in the cup. I want the junk from the lungs. So I have to try to get them to cough. Okay. And that is the only way that we can definitively diagnose a bacteria. And that's across the board for all of nursing school. If they ever ask you, how do you diagnose a bacterial infection? Okay, it's going to be a culture of whatever you're looking for. So let's say you think the patient has a UTI, which is a urinary tract infection, right? Bacteria of the urine. We're going to do a urine culture. No, ma'am. Culture. Let's say we think the patient has sepsis. What is sepsis? Bacteria in the blood. So guess what I would do? Blood culture. It has to be a culture. Okay. Let's say I think the patient has meningitis. What's meningitis? So I'm going to do a CSF culture, a cerebral spinal fluid culture, because that's the fluid that comes all through here and down here. Okay. Let's say I thought the patient had the patient has an abscess. I drain the abscess. How do I know that it is a bacteria? What do you mean by sample? Okay, so we're going to do a wound culture. Okay, we're getting there. Okay, so everything you do, if you're looking for a bacteria, you can only diagnose it with the culture. So you're going to culture whatever that body fluid is or wherever that is that you think that there is an infection. Okay. All right. What is a peak flow? If you don't know, it's okay to say I don't know.
I'm thinking it was like to do with like the cough, like the air. Wait, I was thinking about like maybe like knowing how much air is coming out.
Okay. That's a you explain things in a different way, so I have to always interpret what you're saying.
Yeah,
because when you say it, I'm like, girl, that's weird, and then I'm like, oh, she's not wrong. Okay, so a peak flow is something that we use for our asthma patients, and it basically tells us how good their asthma is being maintained. And I think I have one.
So it's not a diagnostic, but it does help us to see like okay.
All right. So in asthma, they have a hard time getting air out. Right. So, and you're going to have them stand up for this, but this is the little tool that they use. They have this at home and they're supposed to do this every single day. They do it 3 times in a row and then they write down their best one. Okay. So you're going to have them stand up. You take a deep breath and you blow hard as you can. And that will give you a number right here. Okay. And on that number, right, you write it down and then they write it down every single day and they kind of look and see like, what is your best number on a good day? Okay. And then we use that number to determine when you're on a bad day. Okay. So let's say on a normal day, like most days, I'm blowing a 400. Okay. I start to get sick. I'm getting the flu. Okay. Obviously, my lungs are not going to be doing well. They're going to be inflamed and bronchoconstricted. So on that day, when I start getting sick, I blow a 250. Okay. Then we know like, hey, you're not doing very well. You really either need to go to the doctor or you need to go to the ER. And they'll give you a sheet that tells you what numbers you do what. This is a peak flow. Do you understand it? Okay. All right. Next is spirometry, or they might call it a PFT, which is a pulmonary function test.
And what do we use those for? To see how my airway to actually blow out and in.
We want to look both. And you get into this weird glass box, right? Looks like an old school phone booth, but it's glass. And then there's a pipe that comes out of the floor and you have them do different things. They're going to have, it's respiratory therapy that conducts it. And they have them do all kinds of take the deepest breath you can, blow out, sort of blow out, don't blow out a tiny bit. And they have them do all these different things to see what their lung capacity is. We usually use spirometry or PFTs for COPD, and for asthma, because they're having a hard time. COPD has a hard time getting air in and getting it out, and asthma has a hard time usually getting it back out. Okay. All right. What is a pulse oximeter? Mhm. Yep. It's a little thing that goes on your finger. What does it tell you? It tells you, it does tell you the oxygen level, kind of. Yeah, okay, let's explore that. So it does tell you the oxygen level. It's going to give you a percentage on the machine. Okay, so what would a 95% mean?
That you're good decent amount of oxygen.
But pathologically, what does that mean? What does the percentage mean? Like percentage of what? Percentage of oxygen of what? Like a percentage is a percentage of something, right? Okay. Like you need to know the difference. I think I went over this on the video. If
Okay. You didn't see it or you didn't understand it, you should do it again.
Okay. There's a difference between a PaO2 and an SpO₂. Yeah.
Okay, now I remember seeing
All right. What is a PaO2?
the one that
or tell me PA, like tell me anything that you know about the difference between those two, or what are they, or just any fun facts you got.
I'm trying to think of which one got, because I think one of them got sit there. That one.
They both well. All right, so the PaO2 is what we find in our ABGs. We're going to draw it from an artery, and that comes out in our ABG labs. Okay, so that tells me the actual amount of oxygen in the arteries. Okay. The SpO2 is a percentage. That's a percentage of hemoglobin that is saturated with oxygen. Okay. That's the pulse ox, right? So the pulse ox, the SpO2 is going to come in a percentage. It's the percentage of hemoglobin that is saturated with oxygen. The PaO2 is the actual amount. How much oxygen do you have in your blood? And we can only get that by sticking an art line into an artery, okay, and getting that number, okay? All right. Where was that? Oh, well, you're talking about pulse ox. Okay. So the pulse ox tells me my SpO2, right? Okay. All right. Next, let's talk about different procedures that we could do. Do you know anything about a thoracentesis, or have you heard of it? Okay, what does thora mean? Like a thorax? Chest. So your thorax is your chest. And then a centesis always means you're taking fluid out. Okay, so you'll hear like a paracentesis, a thoracentesis, a cardiocentesis. So centesis means I'm getting fluid out. The word in front of it is where I'm getting fluid out from. So then what would a thoracentesis mean? Of your chest. Yes. So let's say you have a collapsed lung because a bunch of fluid is in there. Okay. And it could be a hemothorax, which hemo means blood. So it'd be blood in your chest. If there's blood in your chest, maybe from a gunshot wound or stabbing or something. Could be a pneumothorax. So it's a pneumothorax. Oh, no, pneumo. Like pneumonia, kind of like that. But pneumo means air. Okay. So that would mean air in your chest cavity. Okay. So anyway, so a thoracentesis basically is going to mean that we're going to drain fluid out of the chest cavity. Okay. We stick a big giant needle. Well, you don't do it. The doctor does it. Please don't go in there and try to be like, oh, hey, I heard about this, thoracentesis thing. Let me give it a try. So yeah, I know. Don't write that down. So in a thoracentesis, you're going to stick a giant tube inside their chest cavity. Okay. And you're going to drain out fluid that may have accumulated there. Okay. Pulmonary toilet. Have you heard of this? It's so disgusting, isn't it? Doesn't that sound gross? Yeah. All right. So pulmonary toilet, what is a toilet? It's something that we get rid of waste. Okay. But in the case of your pulmonary system, you want to get rid of mucus. So it's lots of different things that go underneath. Pulmonary toilet is an umbrella, and there are lots of different things that go underneath that. Respiratory therapy will typically do pulmonary toilet, but you do need to know what it is. Okay. So pulmonary toilet includes CPT, which is chest physiotherapy. It's a vest that they're going to put on, and it shakes the patient because it's trying to shake that mucus free. Okay. We do this a lot for like our cystic fibrosis patients. Okay. It also includes percussion. Okay. Did you do band, or do you know anybody who did band?
Yeah.
Okay. The percussion section.
Yeah, it's like the drumming.
Yeah, so that's what we do. We drum on their back, okay? You can either do it with your hands, or they have these little like paddles that you can use, and you're basically trying to break up the mucus in their back, okay? Also included in pulmonary toilets is something else. Okay, postural drainage. Okay, so what does posture mean?
From the way you're sitting, your body.
Yes, so your body, exactly, your body position. And then we want to drain. So respiratory therapy is going to put the patient in all these weird, crazy positions in the bed in order to facilitate drainage of mucus.
Okay.
So let's say we did a chest x-ray and they have a giant amount of mucus right here. Then I'm going to probably put them on this side and kind of upside down so we can try to get that mucus up. Okay, so they can cough it out better. So all of these are included in pulmonary toilet. Okay. And respiratory therapy, like I said, we'll do most of these, but you do need to know what they are. Okay. All right. Next, you need to know your basic medications for respiratory. Okay. We're just going to talk about what the names of the kind of drug classes are, and then we'll go into different meds at another time. Okay. An expectorant. What is an expectorant? All right. So it is when you ask a patient to expectorate, you're wanting them to cough. Okay. So if you give an expectorant, that is helping them, it's going to increase their cough because you want them to get rid of mucus. It's the opposite of a cough suppressant. That's why we don't give cough suppressants. We want an expectorant. Okay. Then mucolytic. What does muco mean? Mucus. What does lytic mean? To lice. What does that mean?
It's like a
If I was going to lice somebody, what does that mean? Kill. Exactly. So I want to kill the mucus. Now, how do I kill somebody's mucus? Mucolytics will thin the mucus out because very thick mucus, you cannot cough up. That's why we have to give respiratory patients 2 to 3 liters of fluid per day. We want that mucus thin. Cough suppressants. Those are a no-go. Okay. Bronchodilators. What do they do? It is an inhaler. And what does it do? What does broncho mean? Okay. What does to dilate mean? Open. So it is going to open the airways, like an albuterol inhaler, right? Okay. Corticosteroids. What's their job?
It is to last what it is involved break, not break.
Okay. Well, let me tell you what they are, because I'm not we've ever talked about this. So corticosteroids are synthetic cortisol and aldosterone. Those are the 2 hormones that are in our stress response. Okay. Now the stress response's job is to come out and tell your immune system, like, you are overreacting and you need to settle down. Like, I need a little bit of you, but our immune system will always overreact. Okay. So let's say a patient comes in with massive bronchitis and they're wheezing because your immune system caused massive inflammation because it knew that there was some kind of infection, but it overreacted. You're going to give them corticosteroids. It's going to tell your immune system, like, sister, settle down. Yeah. So we'll decrease inflammation. So that's what corticosteroids do, is they decrease inflammation. Okay. Nebulizers. Have you seen one of these before? Okay. It's a little machine. They put either mask on, or there's also a pipe that they can use too. Okay. And that will have anything from corticosteroids to albuterol. There's all kinds of things we can put in a nebulizer. And then you know what an inhaler is, I'm assuming. Okay. Now, inhalers, you can either have corticosteroid inhalers, you can have bronchodilator inhalers. So there's lots of different medicines that can come that way. All right, let's talk about basic health assessment of the respiratory system. All right. The best assessment you can do is just to look at the patient, because you can tell a lot by just looking at a respiratory patient. Okay. The first thing I would do is like look at you and be like, what's your color like? Okay. Are you pale? That's called.
Oh,
If they're pale, what's the term for pale? Pallor. If they say the patient is pallor, P-A-L, you need to know that one. Pallor. That means that they are a pale color. It could be anemia. It could be, there's lots of different things. But if they're pale, it's called pallor, which it kind of paler. Okay. Yeah. I can look at them and see if they're blue. If they're blue, what would I document? But what's it called? Patient's blue. Starts with a C. I think you're scared of me just directly asking you questions, because you shut down and get nervous. This is how I teach, sister. So you're going to have to get not uncomfortable, because I'm not uncomfortable. If you saw somebody with blue around their mouth, you're like, oh shit, that patient is cyanotic. Okay. They have cyanosis. All right. Cyanosis means that they are blue, right? Patients can also turn a gray color when they're starting to give it. There's no word for that. It's like they look bad. Yeah. But if you tell another nurse, you're like, oh my God, our patient's gray, and be like, well, okay, I'm coming. Like, I'm going to come help you. Okay. What else I can look at is just how hard they're breathing. You can tell if somebody's working really hard to breathe, right? You can look at their respiratory rate because I can see you breathing. I can look at your chest and I can see how fast you're going. What's a normal respiratory rate in a patient? 10 to 20. Okay, so 10 to 20 is a normal. Write that down. 10 to 20 is a normal respiratory rate. Okay. What are retractions? I can see that with my eyes. Do you know what these are? Yes. Hold on, I have to interpret. I think so. Okay. So you have retractions here if you are working really hard to breathe and it's pulling in, and you can also see them between the ribs. So if they're between the ribs, it's called intercostal. So inter means inside, costal means chest or ribs. Yeah. And then it could also be supraclavicular. So here's my clavicle, my collarbone, and supra means above. Okay, so those are retractions. Diaphoresis. What is diaphoresis? It does not, because nursing school does that to you. Okay. Diaphoresis means sweating. Okay. Diaphoresis. If they are working so hard to breathe, they are sweating. That is always a giant respiratory red flag. Okay. Because if you're just sitting, chilling, and doing nothing, and you're working so hard to breathe that they're sweating, your patient's probably going to code on you. Okay. And then what did pallor mean? Pale. Good. What's a barrel chest? You probably haven't gotten there in the module yet. So barrel chest is, we see this usually in COPD. In COPD, they are trying so hard to breathe in oxygen because remember, their lungs are not compliant, right? So they're with every breath that actually will remodel their chest cavity, and their ribs, because they're trying to suck in, will actually go out like this, and they stay there. And it's called a barrel chest. Okay. Because we should be twice as wide this way as we are this way. And them, it becomes so big that they're like a 1-to-1. They're the same size this way as they are this way. Okay. So that's called a barrel chest. What is nasal flaring? Outside, right here. And usually infants will do this. But because infants are nose breathers, they breathe through their nose. They don't breathe through their mouth. They don't breathe with their chest or their diaphragm. They usually breathe through their nose for the first couple months. So if they're trying to breathe in air, it's coming through their nose. So they are, and you can see them like flare out. That's a giant red flag. Okay. And then you can just look at their chest movement. So in patients, let's say there's been a gunshot wound or a stabbing or something, and you look at their chest and one side is moving and the other one isn't, probably they had a lung collapse. Okay. All right. Next is palpation. What does palpation mean? I'm touching. Okay. And we don't do this very much. We're respiratory. It's kind of weird. Like, I'm not going to be, let me touch your chest, but it was mentioned in your book. So I brought it in. You can feel their temperature. Okay. Now patients in respiratory distress will go one of two ways. If they're working really hard to breathe, they're going to be very hot and flushed, right? Like our asthma patients are usually very hot and flushed. They get asthma gets something called a malar flush, where their whole face gets red because they're vasodilating and trying to figure out, like, trying to get some blood flow. Now, if they're really bad respiratory, they're like near dead, then they're turned cold. Yeah, blue and cold. Okay. PMI. So you can you can palpate their point of maximal impulse. That's the part on the heart where you can feel it beating the hardest. Okay. And then cap refill. Tell me what you know about capillary refill. Good. All right. So we're going to push down. Now I have fingernail polish on, so obviously you can tell. I'm going to push down and then I'm going to let go. And I'm going to see how long it takes. When I push down, it'll turn white. When I let go, it will turn pink again. You want it to be less than 3 seconds. Okay. If you have an increased cap refill, then that means it's taking a long time for your blood flow to fill back up, meaning you don't have a lot of good blood flow. Yeah. All right. Percussion. What does to percuss mean? Yeah. So in this case, we could do something called tactile fremitus. Did they talk to you about this, or have you heard about it? Okay. You usually have in health assessment, but you're going to put your hands on the back of the patient and you're going to have them say something like 99, and then you're going to feel the vibrations. And if you feel vibrations in one spot and you don't feel it in the other, that spot may have an area of pneumonia, because air can't travel through fluid. It can only travel through air. Air travels through air, right? So as we breathe in, that's why I can hear that, because air is traveling through air. Right? If you hear crackles, then that means there's air plus fluid. And that's why you hear that crackle noise. Yeah. So that's what tactile fremitus is. And then subcutaneous emphysema. This one's wild. Okay. What does cutaneous mean? Where's your cutaneous layer? Of your skin. It's skin. So cutaneous means skin. Okay. And sub means underneath. So right underneath your skin. Okay. in some patients that have had air enter their chest cavity, not from this way, but in a bad way, like a stab wound or gunshot wound or something, and air came in, okay? It tries to find a way to escape because there's not supposed to be air inside your chest cavity. So we'll try to escape underneath your skin. So when you palpate that patient and you push, they'll crackle like bubble wrap. It's wild. They go, and you can hear them pop. Yes, it's called subcutaneous emphysema, and you know that there's air in the chest cavity. Okay. All right. And then we're going to auscultate. Okay. We're going to listen for adventitious sounds. Adventitious sounds mean something that's not normal, right? I just want to hear vesicular or bronchovesicular normal breath sounds, right? But what does wheezing tell me? If I hear wheezing, that's an adventitious sound. What does that tell me? It's not fluid. No, that's crackles. You told me that was crackles. Oh. So crackles mean that there's fluid in there, right? Because you're hearing fluid and air at the same time. What does wheezing mean? Because why? No, trachea would be strider, right? Wheezing is down low. Like what? Who wheezes? Like okay, bronchitis wheeze. What does itis mean? Trachea? Sometimes it means infection, but most of the time it means. Yes, you do. I'm gonna wait because I want you to figure this out because you're gonna need to know this for all of time. All right, if your patient has pharyngitis, what does that mean? Okay, what about? I'm trying to think of stuff y'all may have heard before. Well, you said bronchitis. What is bronchitis? It's not an infection. What is it? Why? So what would cause somebody not to get enough air in their airways? What would cause somebody to do that? Sometimes it can be mucus, but most of the time what happens with airways when you get sick? Okay, so they inflame, right? They're inflamed. So itis means inflammation, okay? So if you have wheezing, then that means there is massive airway inflammation. Now the airways were supposed to be like this. Now they're all inflamed. So when you try to pull in air, it's like a teeny spot. It's kind of like when you take a balloon and you pull it and it makes that noise. That's what's happening. It's squeezing your airways. So wheezing tells me that there is bronchoconstriction. Broncho is like your airways. Constriction is to constrict them, to swell. Okay. And then what does crackle? What do crackles tell me? You've got mucus inside of there somewhere. And then rails. Have you heard of rails? All right. So rails are just like, only way I can explain is like, you got some junk in there. It's not crackly. It's not wheezing. But I can hear like, yeah, there's some junk in there. Okay. All right. Let's talk about the different nursing diagnoses that you could choose for a patient that has a respiratory problem. Ineffective airway clearance. So will always be your number one. Okay. Because if they don't have an open, basically what that means is they don't have an open airway. And that usually is either from inflammation, okay, or mucus. Okay. Ineffective airway, if their airway is not open, it does not matter about gas exchange because you can't even get air down there. That's why it's your priority number one. Number two would be impaired gas exchange. Now, in order to say there's impaired gas exchange, then I need to know what two gases.
Oxygen.
Okay, so what's either my SpO₂ or PaO₂, or what's the other gas? Sorry, what exchanges? Or carbon dioxide. I need to know those levels, and I can get those out of my ABGs. Okay, so if I did an ABG on a patient and their PaO₂ was 60 and their PaCO₂ was 55, it's very bad. I could definitely say that they have impaired gas exchange. Okay. And then the last one is an ineffective breathing pattern. Now that will always take third priority. That is never going to be a first because ineffective breathing pattern is a consequence of either impaired gas exchange or ineffective airway clearance. Okay. All right. So what are we going to do for a respiratory patient? Number one thing you do for a respiratory patient. What's the first thing you're going to do when they come in the hospital? Mm-hmm. No, man. First thing you do. I already told you, pick this as a priority all the time. Don't look at your papers. Use your brain. You're smarter than you think you are. You're just not trusting yourself, so you're trying to find the answers. If somebody can't breathe, I told you always pick this first for all of nursing school. If it's the correct, then you're going to pick it. Positioning. So what's the first thing you're going to do for a respiratory patient? Sit them upright. Sit them upright. What's the first thing you do for a respiratory patient? Good. And then we can put them on a pulse ox, right? And then I can look at their breathing. What's your chest looking like? Are you cyanotic? Do you have pallor? Are you retracting? Do you have flaring, right? We're going to look at all those things we already talked about. Then once we assess and the doctor is diagnosed and we have a plan of care, then I can start implementing things to do to help them breathe better. We can do the incentive spirometer. How do you do an incentive spirometer? It's not the same as spirometry. No, that's a peak flow. Remember, we blew into this one, right? Mm-hmm. It's not to see how much air they're taking in, it's to make sure their lungs are expanding. So like after surgery or if they're in pain, when patients come out of surgery, they breathe like this. Now, what happens if I'm only breathing like this in my lungs? What's going to happen to the bottom of my lungs? They're going to stick together.
Yeah.
That's called atelectasis, right? Okay. And atelectasis is going to cause the bottom of my lungs to stick together and they're going to start rubbing. Well, your lungs are mucous membrane. So in order to protect themselves from that friction, they're going to produce a bunch of mucus. Then that mucus is just going to sit there and they're going to get pneumonia. Yeah. So there's a ton of post-op pneumonia and that's the reason why, because they're shallow breathing. So our job as the nurse is to make sure that they're taking big, deep breaths so we don't get the atelectasis and the rubbing. Okay. So in order to do that, it's that little machine. I'm sure you've seen it. Have you been in? Okay, great. Then you haven't seen it. But it's a machine that's like at the bedside. I say machine, but it's portable. You can carry it around. It's not connected to a wall or anything like that. And there's like a little pipe thing and you put the end of that in their mouth. And instead of blowing in it like you would a peak flow, you want them to, and it has a little ball just like this. Okay. And it will show them how much they're taking in. You have to encourage them. That's why it's called an incentive. I'm like, let me incentivize you to take big, giant, deep breaths so you don't get pneumonia. Okay. People use the incentive spirometer wrong all the time. Okay. And the nurses will tell blow in it. Well, that ain't doing anybody any good. I don't need you to blow on it. Okay. I need you to hyperinflate your lungs. Yes. Okay. Next is, you will see this on all my handouts, TCDBQ2. Okay. That is turn, cough, deep breathe every 2 hours. That is going to help your patient. We're going to move them. That's going to help with postural drainage. So that's turning. We're going to encourage them to cough to get up the mucus. And then we're going to tell them to do our deep breathing. You can either just tell them, hey, take some deep breaths with me, or you can use the incentive spirometer. Okay. All right. Oh, okay. Well, tell me to stop if you're doing that. Okay. All right. Next, we can teach them pursed-lipped breathing. Now, this is good for our COPD patients. Okay. Now, they trap too much CO2, which can make them acidotic. So when we're teaching them to breathe, we want them to breathe in for 2 and out for 4. Okay. So that's going to help them blow out all of their CO2 and be less acidotic. Okay. Tripod positioning. What does that look like?
Is it like where you're like spread open?
Hunched over. Now we let them sit in that because remember I told you what's the number one thing you do for your respiratory patient? They're sitting upright. Okay. So the more upright your patient has to be, the more respiratory distress they're in. If your patient can chill in semi-Fowlers, they're not in respiratory distress. As soon as respiratory distress patients come in, we sit them on high Fowlers. Okay. And some people may be in such respiratory distress, they actually lean over. Okay. But it's kind of like, whenever do you run or anything? Okay. So, when we run and we're getting tired, we naturally go like this, right? That's because it's pulling our lungs forward and allowing more expansion. Okay. That's basically what they're doing in the tripod. They're just sitting and okay. All right.
That makes sense.
Diaphragmatic breathing. So most of us don't practice diaphragmatic breathing. We breathe from our chest. Okay. But that's only really inflating the top part of my lungs. If you want to teach them diaphragmatic breathing, your diaphragm's down here. So you want to teach them to breathe with their stomach, not with their chest. It's different, but it gives you so much more air. So you want to see their stomach go out when they try it. It's wild. We breathe like
different.
And it doesn't really do much for us, to be honest. Diaphragmatic breathing does. If you practice meditation or yoga, that's what they'll always teach is put your hand on your belly and you want to practice diaphragm breathing. You also do it, they do it for choir, like for people that sing, because you need to learn to practice diaphragmatic breathing because you'll have much more airflow and you can sing for longer. So lots of arts and practices like that will practice diaphragmatic breathing because you breathe better than just breathing with your chest. Okay?
You should go.
Oh, it's totally different.
You feel that and your chest.
Yes. So your diaphragm is meant to work together, but we don't really use our diaphragm. So our breathing is really terrible. Okay. All right. And then the last one is to promote coughing. They may tell you to use something called a huff cough technique. Okay. And that's basically where you're trying to make the patient cough. You ever been sick, like flu, bronchitis, something, and like if every time you take a deep breath, it makes you cough? That's what we want them to do. Okay. Huff coughing technique is one of the things they may use. So you may tell them to take the deepest breaths that they can to initiate the cough reflex and then like make themselves cough to get up the mucus. Okay. All right, goals for our patient. Oh wait, no, I didn't finish nursing care. Sorry. If their throat is sore from coughing or what have you, you can provide some throat lozenges. Just don't pick those for little kids under 4 because they'll choke on them, Moppy. Okay. Increase fluids to 3 liters a day. Why do we do that for our respiratory patients? Yes, we want the mucus nice and thin. Good hand washing. This will always be what you pick 100% of the time on every exam in the history of all time. I do not care if they ask you what t-shirt is your instructor wearing. Good hand washing. You're just going to pick it. It is always the answer. Okay. Expectorants. What do we say expectorants were? Yeah, makes you cough. So it helps you to be able to cough up all of that junk. Okay. Because we do not want suppressants, right? No. All right. Goals for our respiratory patient. You want an SpO₂ greater than 95%. That tells me that greater than 95% of their hemoglobin is saturated with oxygen. That's why we call it an O2 sat. Do not call it an O2 stat. Yeah, they'll make fun of you in the hospital for that. That's why I always tell students that, because you're not like O2 quickly. That's not what it means. It's an O2 sat, an O2 saturation. Okay. You want to make sure they have no pallor. What did pallor mean? Pale. No cyanosis. What's cyanosis? Blue. No increased work of breathing. These are not. We just want them normal breathing. Okay. We want clear breath sounds, right? Vesicular and bronchovesicular breath sounds. And we want normal ABGs. Okay. Do you understand the basics of your respiratory patient? Was that helpful?
Yeah.
Good.